Good afternoon, everyone. And thank you, Melissa, for such a wonderful introduction. So I'm just going to start my presentation about cervical cancer in low resource setting. So cervical cancer is one of the most common cancers among women in the world. In 2012, about 500,000 women had a new cervical cancer cases, and 265,000 deaths due to cervical cancer in the world. And cervical cancer is one of the most prominent example of disparity in the world because being a preventable disease, it still causes a major burden in developing world. So 85% of the cases are from the developing countries. HPV, human papillomavirus, is a known cause of cervical cancer and is attributable to more than 90% of all cervical cancer cases. And specifically, subtypes 16 and 18 are responsible for 70% of the total cervical cancer. And cervical cancer is preventable. There are two distinct strategies. The primary strategy is to do vaccination against HPV, and the secondary strategy is to do cervical cancer screening and treatment. So HPV vaccine has been shown to be very effective in developed countries. This is data from Scotland. They started the HPV immunization national program in 2008, and then they analyzed the data among the birth cohorts from 1988 to 1992, who also attended the Scottish cervical cancer screening program. And they found that there was almost 50% decline in cervical cancer incidence rates among those who were vaccinated compared to those who weren't vaccinated in all birth cohorts that they analyzed. However, implementing vaccine in low resource setting is very challenging because of two distinct reasons. First is the cost. For example, in the US, it cost about $360 to get 3 doses of vaccine. Gavi is this Global Alliance for Vaccination and Immunization. They negotiated the price up to $15, about like $13.4 per person, which is still high in terms of going nationwide in developing world. So the affordable price is really if it comes down to $1 to $2 per person. And there is also a huge social stigma related to sexual transmitted infection. So even if the cost comes down, it would still be challenging to reach to the adolescent boys and girls in this part of the world. There are 3 widely available cervical cancer screening strategies: the cytology evaluation, visual test, and HPV infection test. Cytology has been shown to be very successful in developed countries. So it was started in 1950s, and there has been shown large decline in cervical cancer incidence as well as mortality, and all of these is attributable to the pap smear test. You can see that the Finland is the green bold line and the black bold is the US, where you can see the huge decline from 1957 to 1997. And it is majorly attributable to the pap smear test. However, the cytology program requires lab infrastructure, trained specialists, quality control, system of communication with the women, and multiple visits. All of these are not possible in the low resource setting. So it's been not very appropriate in that setting. Then comes VIA and HPV testing. So this is one of the largest studies that was conducted in low resource setting from India. It's a cluster randomized control trials with 131,000 women. And they randomly assigned women into 4 groups: HPV testing, cytology testing, VIA, visual inspection with acetic acid, and control group. I'm just going to present the main results. What they found after 8 years of follow-up was HPV testing was significant in reducing cervical cancer. In screening cervical cancer, incidence, advanced stage of cervical cancer incidence and mortality by almost 50%. However, in that setting, cytology test and VIA test was not significantly effective. Another study from South Africa, which is also considered one of the very prominent studies in this area, is they randomly assigned women to HPV treat and visual infection and treat and control group. So everybody got HPV testing and VIA testing, but they randomly assigned the treatment based off whether it was HPV positive or VIA positive. So they published two papers. One was at 6 months, and then they published a follow-up paper at 36 months. This is the results from 36 months follow-up. And they found that both methods, VIA and HPV, was effective in reducing the prevalence of CIN second grade and CIN third grade, the pre-cancer. And HPV and treat strategy was, however, more effective than VIA and treat strategy in that setting. So HPV and VIA also have their own limitations. Like HPV is still very expensive and it's not readily available in low resource setting. And it has low specificity, so there is over-treatment. Similarly with VIA, the accuracy of the screening test really depends on who is testing. The specificity is low. There is no permanent record to review and then cross-validate the screening results. It also requires spaces, equipments, and supplies, and pelvic examination, which is a stigma in a low resource setting. So it is difficult to say like which test to use, like how to save women from cervical cancer in low resource setting. WHO came up with this algorithm. So they gave this guideline to decide which test to use based on what resources are available. So if there is enough resources and you can assure the quality, quality control, then go for cytology or HPV test with colposcopy. If there is no guarantee of quality control, then go for HPV testing followed by VIA testing and cryotherapy. If there is no resources, just do HPV testing, and even if there is no resources for even HPV testing, then just do VIA testing. So this is like a broad guideline provided by WHO, and many low resource setting countries are following this guideline. Nepal is also following this guideline and adopting VIA and VIA alone and cryotherapy to reach population nationwide. So coming back to Nepal, just to give you a little bit of background, Nepal is a tiny country in Southeast Asia. It's between India and China. Compared to US, it is 67 times smaller. It has 11 times fewer people. GDP is only 4.3% of the US GDP, and life expectancy is about 71 years, which is 9 years less than the US population. So, sorry, this is intended. I wanted to show you a video before I move forward. Okay. So somehow the hide didn't work, so another came up. Okay, excuse me. So in Nepal, cervical cancer program in Nepal, it is almost non-existent. There is any provision for HPV immunization. There is National Cervical Cancer Screening Guideline that was endorsed in 2010 that aims to target about 50% of women using VIA and cryotherapy, but there is any systematic or organized screening program. So the only about 3% of women are reached, and that's also opportunistic. screening. And the population-based cancer registry started only in 2018, so there is no way to say like what is the real burden of cancer. But we, from like other indirect sources, we can say that it's the burden is really high. So we started this cancer screening program in rural Nepal through the Kathmandu University School of Medical Sciences. They have cancer prevention program. And just to, I'll show you a video just so that you get a context of where this information is coming from and how people are working there.
Nepal, the land of Mount Everest, with diverse ethnicity, religion, culture and tradition, yet people living in peace and harmony, a country of unity in diversity. 80% of the country's population lives in the rural areas, and Timal is one of them. Though the place is just 75 kilometers far from the capital Kathmandu, it is one of the remotest areas of the country. In this male-dominated patriarchal society of 30 million people, the lives of women is not same all over the country. The life is totally different in the way the city women are living and how the women of the rural areas are struggling for their everyday's living. Here, the women are the one early to rise and late to eat and sleep. They are the less privileged people in every aspect of living. They are socio-economically and culturally predisposed to various women's health issues, including cervical cancer and its risk factors, which includes early marriage, giving birth to multiple children until they give birth to a son, polygamy, poor hygiene, cigarette smoking, and sexually transmitted infections. Seems like all these ill health has been ignored by these women herself, but the truth is totally different because they are completely unaware of these diseases and the risk factors that they are living with every day. The nearest health center is an hour's distance, and they merely seeks or goes there for healthcare service unless it is too disabling them. Most of them die without seeing a doctor in their whole lifespan, or some of them land up in the hospital at the advanced stage of disease. So it is us to reach them until they can reach us. And this is what I have often heard Dr. Ram, the pioneer of Thulikil Hospital. Since I met him 12 years back, I saw him doing the same. He established the Bolde Outreach Center, a subsidiary of Thulikil Hospital, where round-the-clock service is available and is offered through resident medical doctor, a paramedic, and the auxiliary midwife. We did a small study among the women living in this village to find out how many of these women knew about cervical cancer, and out of them, how many are prone to develop it. Surprisingly, the finding was there is lack of knowledge on their own reproductive organs and on cervical cancer among these women. And none of them have ever heard of the term Pap test, and most of them have never undergone gynecological checkup. A year after that baseline assessment, in collaboration with NTNU, the cervical cancer prevention program was started in Timal region, thus enhancing the globalization program of NTNU. Management of cervical cancer screening program in each VDC begins with meeting with VDC health force in charge, female community health volunteers, teachers, and headmasters to decide on how, where, and when to conduct the awareness and screening program in their community. And accordingly, verbal invitations are sent through them to rest of the women in the village. In each VDC, multiple educational programs are held
पाठेघरको मुखको क्यान्सर लागेका महिलामा सुरुमा लक्षणहरू केही देखिँदैन।
हेर्नु त यो के जस्तो छ तपाईहरुको? On the day of the screening, our screening sites are 3 to 4 hours drive from Dhulikhel Hospital and further have to walk for half an hour to an hour. The screening sites chosen by the community can be sub-health post, school buildings, or the cooperative houses. Our first job is to set up a mobile clinic over there.
कति वर्ष हुनु पर्यो?
34 श्रीमान अस्ति नै
विदेश जानु भएको छ हैन?
फागुनमै त
बिहे कतिपल्ट गर्नुभयो?
3 पल्ट।
बिहे
For those who are hesitated to take part in examination are further counseled once again in a group. On the same day, the samples are taken to Dhulikhel Hospital's molecular and the microbiological laboratories.
ओडामा गएर हैन हरेक महिला दिदीबहिनीहरुलाई भेटेर पाठेघरको मुखको क्यान्सर बारे हजुरले चेक गरेर पाठेघरको क्यान्सर भएको भनेर सुन्नु भएको छ भन्दाखेरि छ भन्ने कमै मात्र भेटेको छ। हामीले एकदम कम भेटेको छ। हामीलाई नै पनि ट्रेनिङ दिँदाखेरि नि पाठेघरको क्यान्सरको बारेमा हामीलाई पनि सिकाएको थिएन। मलाई पनि यसरी गर्ने भनेर एक दुई जनालाई सिकाइस्यो, एक दुई जनासँग सिकाइस्यो अनि यसपछि यसरी गर्नु भनेर चाहिँ उ गरिस्यो भने म यसमा सक्छु गर्न।
These women, they are not coming to the clinic and they don't have access to the hospital. Sitting in the clinic and solving on one-on-one basis, it doesn't work for Nepal. Once we finish the screening program in one VDC, the same process begins for the next.
So this is how things work over there, and 80% of people in Nepal live in these kinds of rural areas. So there is very limited access to healthcare, and even to provide, just to have a contact with health worker is a big thing for a woman who is living in the health, like in these kinds of rural areas. And this is one of the accessible areas. So there are areas where you would have to walk like 4 or 5 days just to like reach to that area, because there is no road, and Nepalese, 2/3 of Nepal is all hills and mountains. So it is challenging. So we started with a feasibility to see whether or not it is feasible to conduct cervical cancer screening in the at community, because if we call the women to the health centers, then it is very unlikely for them to come. So. And a lot of other health services in Nepal, like immunization, family planning, safe motherhood, are also delivered through the outreach clinics, something like this. So we started with a small feasibility study with 122 women, and then we provided them some health education, about 1.5 hours of discussion on what is cervical cancer, like how to seek the cervical cancer screening services, and how to like follow up if the test is positive. And the main message was cervical cancer is preventable. And then we asked them to come for the screening after 15 days, and then we asked them to give these messages to their peers as well. So these are the characteristics of the women. Most of them were in the early reproductive age group. Majority were illiterate, 62%. They have their own income. It is because we reached them in their microfinance group, which is the specific groups that are formed in the villages in Nepal. And most of them, even more than 60% of them, were married before the age of 17. And like more than 50% have like 3 or more children. So we asked them if they have ever heard about cervical cancer. Only 6% had ever heard about cervical cancer before the health education class, and none have heard about HPV or pap smear test. So you also saw that in the video that we did education session with these women, and after this session, so before and after the session, we asked them whether or not they are willing to undergo a test for cervical cancer prevention if it is offered free of cost. Before the education, only 16% said that they are willing. After the education, like all of them said that they are willing to undergo the test. So on the test day, all of them came. All of them who received the health education came in, and then they brought their peers. So we were able to test 344 women. 122 were those who received the education, and 222 were their peers. The test positive were 13. They were brought to the hospital for colposcopy, and we found one cancer who was treated at the hospital. Another study that we did was to look at the prevalence of HPV infection among rural women in Nepal. And then this was, we also had the same approach for this. We went to the villages and then conducted small group meetings on STIs and cervical cancer, and then asked them to come for a screening. The participation rate was 56%. The characteristics of the women were similar. They were mainly in the reproductive age group, like early age group. Most of them were illiterate, 84%. More than 50% had married before the age of 19, and majority of them had 3 or more children, and 24% were smokers. The overall HPV prevalence was 14.4% in this population. The high risk was 7.9% and the low risk was 6.5%. And the 5 most common HPV types of HPV in Nepal was topmost was the HPV 18, and then 51, 59, 31, and 16. And we thought that it was important to profile the prevalence of HPV types, because it might help us to, when the time comes, to decide on what kind of vaccine that we want to choose. But there is a long way to reach there. Then we also did a feasibility of a visual inspection with acetic acid. Same approach. So the VIA was actually not done at the outreach clinic, but we trained the nurses at the outreach centers. So we invited 20 nurses from the centers that were already working in the health posts and health centers in the rural areas. And the women went back, and then they provided education to the nurses went back, and then they provided education to the women in their villages. And then they invite them for the VIA testing in a predetermined area. This is, I only have a preliminary findings to present here, but 9% were VIA positive. And you can see that by the place of screening, the positive percent varies a lot. And our hypothesis is that it is because of different levels of skills of women who are performing the VIA test, because it really depends a lot on who is doing it, and it is very difficult to cross-validate because there is no record. You just see and then you decide, and that's done. And then we asked all of the positive women to come to the hospital for further checkup, and not surprisingly, only 30% ended up in the hospital. So our experience so far is that it's very difficult. First, it is very difficult to reach the women. Second, it's even more difficult to bring it to the health center. And third, like even much more difficult to provide them the treatment to those who are most in need. Right now, the government of Nepal has just adopted a WHO package of essential communicable diseases intervention for primary health care. So the long-term plan of government of Nepal is to provide cervical cancer screening to all over the Nepal through its network of health centers in all of the villages. However, none of the health centers are equipped, and a lot of and the health workers have not received training in VIA. So we are partnering with the NHTC, Nepal Health Training Center, to provide VIA training to the government health nurses. We've finished 5 batches of 20 women so far, but then also NHTC is also partnering with other institutions all over the Nepal to provide such kinds of such training to their nurses. So at the Kathmandu University, what we are doing in near future is we're doing an implementation trial so to help government of Nepal to scale up this VIA cryotherapy single visit approach, and we're implementing it in 22 villages, training the nurses, and then then measuring the acceptability, adoption, feasibility, fidelity, penetration cost, and the cost for sustainability of the program. And this is what is really lacking to the government of Nepal, because there is a lot of plan. There is a strategic plan, there is guideline, and now they endorse this packages, and there is a list of all the equipments. Everything on paper looks so good, but the implementation is like really poor. So we want to help them get the appropriate information to scale up this program. And next thing that we're really interested is introduced Care HPV to that program. However, it's been, the Care HPV also looks very good on paper. The cost, with low cost point of care HPV testing, but the country-wise price is still high because it has not been negotiated in a group. So the price quote that we got from Care HPV is $25 per person, which is really, really high in our setting. So we have not been able to even pilot test it, but we're negotiating the price to pilot test this in the area where we work. So that's the update. Thank you.